Welcome to Key Into Quality, the Mayo Clinic podcast, where we explore the people, practices, and ideas that help create safer, more effective, and more compassionate care. I'm Dr. Tim Morgenthaler, a professor of medicine at Mayo Clinic and a vice chair for quality. Most healthcare professionals spend years learning how to diagnose diseases, interpret tests, and deliver treatment. But what if one of the most powerful tools that we have for improving care isn't a new technology or a new procedure or a new medication, but the way that we communicate with patients? Can communication skills be improved through coaching? And if they can, does that make a measurable difference for patients and clinicians? Today, I'm joined by my co-host, Sherry Nemec, while we discuss this. Sherry?
Welcome, everyone. I'm Sherry Nemec, Consultation and Relationship Manager for Quality at Mayo Clinic. Dr. Morgenthaler, I agree 100% about communication and building relationships between provider and patients being, a powerful tool not only for improving care, but also for improving patient and provider experiences.
Yeah, there's so often this comes up, it kind of sneaks up in the background, sometimes really kind of overcrowded by news about, new fancy treatments or new diagnostic tests and things. But, I think when you look at most care that's delivered, whether it's in the hospital, the acute care setting, the intensive care unit, and particularly over longitudinal care, communication is hugely important, and not just what is being communicated and how well, but how it's being communicated. So when we talk about quality improvement, we, I think, very often focus on processes and technology and outcomes, but patients experience healthcare largely through conversations. They want to feel heard, understand what's happening, and trust that their concerns matter and that they're heard. For clinicians, these conversations are very meaningful as well, but they can be challenging sometimes to really fit that in, that very important thing, into our daily work. So today, we're going to discuss a pilot study of individualized clinician coaching and communication training that took place here at Mayo Clinic in primary care. And we're going to see what it can teach us about improving patient experience. Joining us are two leaders in this work. Dr. Summer Allen is a physician principal investigator for a study that was done here, and I think helped design the intervention, along with Jennifer Bold, who is a nurse practitioner and principal investigator and co-leader of the project. Thank you both for joining us. I'm just wondering if maybe to begin with, I could ask each of you to briefly introduce yourselves and tell us a little bit about how you came to be at Mayo Clinic and how you got interested in this project. Maybe I could start with you, Dr. Allen.
Certainly. Thank you for having us. So my name again is Summer Allen, Dr. Allen, and I am one of our family medicine physicians and currently practice in the Rochester practice at our Northwest Clinic. And I became involved in this project as having been a former colleague of Jennifer's in Baldwin and my experience previously in patient experience. If you're asking though also, Dr. Morthaler, about how I got interested in patient experience, I would say that's a slightly different question, but I'm going to let Jennifer introduce herself first, and then I could answer that one.
Fair enough. Jen?
Hi, thank you. I'm Jennifer Bold. I'm a family nurse practitioner. I've worked in the Department of Family Medicine since 2005, and I've been a nurse practitioner for 23 years. And I actually had a curiosity about patient experience. I have the luxury of not only caring for a panel of patients, but I also help onboard our new NP and PA staff. And I have been a nurse practitioner for quite some time, and I remember back in my training that I didn't really have training about how to speak to patients. And
Yes.
I was aware that Mayo, we have these coaching services available for clinicians to engage them in learning more about patient experience. And so I had a curiosity about it, about how maybe I could better care for my patients, give my patients a better experience, speak to them, and also what I should be maybe modeling for new staff coming on, helping teach and coach them about how they can improve this skill set as well. So I had this curiosity about, wow, can I be doing more for my patients? And so I started to engage in coaching. And I found that it was really a very eye-opening experience. I worked with my coach for 4 months. We met once a month over Teams, and we had really, Chad, my coach, helped me really take a honest look at my communication, where I was strong, where I struggled. And he gave me some really practical empathic communication strategies that I could start using right away in the clinic. And he made me practice these skills. And then we would come back again the next month and talk about how that went. And then he actually did something that made me really, really nervous. And he came and watched me for a half a day see patients. And I know many clinicians who are listening to this are probably thinking, oh my goodness, I can't imagine somebody watching me see patients. But it was a great experience. And he really opened my eyes to really what I could be doing better. His feedback wasn't about what I was saying to patients, but really how I was saying it to patients. He encouraged me to make small changes, tone, word choices, pauses, presence, really making sure my patients understood that I was listening to them. And what happened in that time was I really started to make those changes in my daily practice. And my patient experience course, of course, started to rise, but something else happened too. My interactions with my patients felt better. They felt more human and more connected. And I also noticed that my joy in practice increased. I felt less burnt out. I really felt energized at the end of my day by my patient visits and not drained. And in my final meeting with Chad, I told him how impactful that the experience has been. And I said to him, you probably know this already works, this patient experience coaching. You probably have the data to show this. And he said to me, actually, Jennifer, we don't. We've never studied whether what I do with
Ah.
clinicians every day is effective. And it was really at that moment and that conversation that started me on my journey to do this study. And that's how I reached out to Dr. Allen. We've worked together for a number of years. I knew that she was very interested and an expert in this topic as well. And we began to go down the path of really looking at whether engaging in patient experience coaching in primary care can help improve patient experience for our patients.
I just love that story, Jen. And it's exactly why I get so excited about coming into practice at Mayo Clinic every day is because we're surrounded by bright people like you who get curious about like why are things the way they are, or does this really work, or is there a better way to do this? And then they take the time to say, oh, let's find out if anybody knows anything about it. They don't. And then you go to that next step of, like, well, let's improve it, or let's study it, or let's do both. So thank you so much for that.
Dr. Allen, let's go over to you and hear your story.
Thank you. Yeah, and again, Jen expresses so much of it beautifully. And I would say, again, my journey into patient experience, we talked about it, is I'd really say understanding how people experience. And I choose the word or choose the term people for a very specific reason, right? So how people experience care is key to their journey. And often we hear about it as patient engagement, but patients are actually people, just like us. And no one is more actively involved or engaged in their health than that person that lives it every day. Now, how they choose to interact with our system, how they choose to live their life each day or explore healthcare, that can all look vastly different. But I have heard for many years, well, people are not engaged in care, or we need more patient engagement. Again, they are the ones living every day with their condition. And so I started to think about, how, when, why does someone choose to interact with healthcare? How do they navigate the system? And the value that each member of a team can bring with each interaction was why I was most interested in patient experience. Because our training in our roles can be different, yet we each have value. And that's where the opportunity really lies, is in each interaction that we have and what difference can we make for the person in front of us. So that's what brought me to patient experience, was to understand that more.
Well, so Jen described, sort of the germ of, gee, we should not only do this but study this.
Correct.
who did you involve, Dr. Allen, as you started this work?
So as we started to explore this work and started to understand, as Jen, shared her experience and said, "Gosh, I want to study this more." Some key aspects of it was, and given prior experience in efforts to improve patient experience and support clinicians, we understood that key colleagues that were necessary for the work were going to be our experts in patient experience. So we enlisted a coach, happened to actually be Jennifer's coach, Chad. So staff from the education and training staff within patient experience for support in the communication class and the coaching that was going to be offered, along with an advisor from our patient experience team to help us understand and make sure that we were setting up our study design and collecting data in the way that was consistent with gathering the information we hope. So helped us survey data collection and helped us stay consistent with institutional goals. Another key component that we recognized was getting department leadership support. So we also understood in this project we were going to, if we were going to look at it within primary care, we were going to need to speak with the key stakeholders within primary care in order to support this study in a way that it could be explored, but also had true potential for further study and implementation in the practice. One of my greatest frustrations is to study or explore something and be like, oh, it's fun, it looks great, but we could never actually do this, right? So wanted to make sure that if we were going to study it, was it something that could be carried forward?
So you mentioned getting approval from leadership as one of those steps. Were there other challenges or things that you encountered, interdependencies that had to be addressed for the project?
Great question. Yeah, so as I shared again, that approval through leadership or getting their support so they understood the project. Another component, and all those I think again here, those listening would understand, was as we designed the project, we thought about, okay, what is time for clinicians going to look like?
Yeah.
Right. Everyone right now in practice is strapped in. So if we were going to design something that asked clinicians to come in early or stay late, did not work within their workday, it was going to be a challenge for them, understandably, right? And we didn't want to do that. We wanted to fit it within their clinical day and make it as um, little a disruption for them in getting their day-to-day work done and still have that impact and support them. So we were really cognizant of how we integrated the coaching aspect. And then also when it came to the communication and for those in that part, trying to incorporate that within the workday. And along with that, was understanding that as we were designing this, and again, I said we had that initial buy-in, right? Which a lot of times leaders say, sure, sounds great, explore it, go and do it. But we wanted it also to be not only sure, explore it, but hey, we're behind these tools, this experience for our clinicians and for our patients, and come back because we want to look at how to integrate this into the practice. So, truly having that buy-in from the leaders and being able to share this, which Jen's positive experience. So against having someone experience this, and I often have told people if you can start small and get some key frontline staff who have buy-in into it, it also helps when you're trying to bring this project through, is to have someone say, hey, I already participated in something like this, or did coaching, and this is the positive experience I had. So we utilize that as well. And then the other challenge was really trying to understand those metrics, right? As Chad had told Jen, we hadn't studied this before. So what were key metrics for not only the institution and for leadership, but truly for our clinicians so that they had the buy-in as well. And then ultimately for our patients, what was going to matter out of this for patients? Where was the difference going to occur?
So I want to take a pause and just gather some of the things that you've said
Yeah.
together to get it organized. So what we heard was, Jen's story about being curious about how she may or may not change if she engaged a coach, and she did that really out of a sense of, gee, I'd like to see what that's like. She had a very positive experience, assumed that they had data that show that this is great. Why aren't we doing it everywhere? And kind of heard, no, not really. And so you all designed a project, and the project was going to be at your particular clinic, primary care. You were going to make available to your colleagues coaching, and I want to come back to that because I want to know more about that. And then you are going to measure the effect of that coaching and with using some metrics, and I want to come back to that too. What in terms of the intervention that you were considering and having to kind of sell leadership on and sell your colleagues on, what would that have looked like if I, like if I was working in your clinic? What is it that you're signing me up for?
Yeah,
Yeah,
so
go ahead,
we
Jen.
we actually
Yeah.
had two interventions.
Yeah.
Coaching was one option. So this was a randomized
Ah,
study, right? You were either randomized to do coaching, or you were randomized to take a communication class, because we do offer and have communication classes that are available to clinicians within our organization. And many new clinicians actually have to engage in some form of a communication class. And so, again, that was another intervention that we use within our organization and within primary care to help clinicians improve their communication skills. And so we wanted to see if either of those interventions were effective compared to no intervention. So then there was just a group of clinicians that continued on their day. They engaged to be in the study, but they were randomized to continue their usual care.
so and so the educational modules, will say these were mostly online modules. Is that accurate, or were they some attendant classes as well, or?
Yeah, so that's a great question. The communication classes were actually over the clinician's lunchtime. It was a 1 hour in-person communication class in which our coach, who normally teaches these classes,
Mhm.
engaged these clinicians in this group to learn about empathic communication strategies that they can employ in their daily practice. And then the coaching sessions were either on Teams, one-to-one individualized coaching, or the coach was in person with the clinician watching them for that half a day, like I had experienced as well, seeing
And
patients.
was the time commitment on the part of the clinician roughly the same? I mean, I realize like if a coach is in my room watching me for a half day, they're there for a half day, but I'm not investing an extra hour of my time. I'm getting feedback. I mean, is the time that I would devote to, either arm A or B about the same?
Correct.
Uh,
They were similar because the again that coaching, the first session was really to set goals, and that occurred, roughly in about a half an hour time frame. The second was just observation. There was really no feedback or coaching, right? It was just observation that was done. And then that third session was another about half an hour. And so there again was an hour and was equivalent to that hour communication
Okay.
class that was offered over the lunch hour. Now, interestingly, a fourth session from a coaching perspective was made available as a option if they wanted an additional coaching session. And all that were within that coaching group all elected for that fourth
Ah,
coaching session.
they found it of value. Yeah. So, okay, so you've got the experimental setup. I'm enrolled as a clinician, and I'm either getting nothing new, or I'm getting an educational class about empathic communication over my lunch hour. I assume you served me something very good, like a stale sandwich, or because that's what usually happens, or
Unfortunately.
or I'm getting coaching in three little snippets, and there's a bonus fourth if I choose to take the fourth. So that's the experimental setup, and the nature of the material that you're teaching. It sounds like really is about empathic communication, listening skills, um, dramatic use of pauses, probably teach back or hear back, those types of things. Am I hitting on the right sort of contents of the educational classes and coaching sessions?
Those kind of key components were involved. And I would say, yes, it was slightly different in the coaching aspect, again, given the individualized nature of it, by design, in the sense that Chad was able to tailor some of the um, education or information shared based on what was observed,
Sure,
right?
there's going to
And the
be,
goals of the clinician.
right. There'll be much more about body language, facial expression, tone,
Correct.
and things that one can't do with an educational one-way session. So you've got this set up. You went ahead and you did this. Now, how long was the intervention at least for your project. We'll come back to the larger project, but for your experimental setup, how long was the intervention between measurement A and measurement B?
So the intervention for the class group was just that 1 hour noon hour session.
Mhm.
The intervention for the coaching group was a monthly coaching session for 3 with an option to extend to that 4th month. And so, Dr. Allen alluded, we had everybody in that arm did do that 4th month. And then we followed their patient experience scores for a year following
Ah,
the intervention being completed.
So we've got the design, you've got the measurement plan, which is patient experience baseline and a year afterward. Did you also measure things from the clinicians involved?
We did. We were interested in burnout as an exploratory measure. As I mentioned, as part of this experience, I felt less burned out in my practice and found more joy in my practice. And so we did use the Maslow's burnout inventory that was that information was collected from clinicians at the time of enrollment in all 3 groups. And then we had sent them the MBI surveys following the completion of the first intervention, and then 2 months after their intervention was completed. Unfortunately, we had low completion scores for the MBI, and so we really could not draw many conclusions from our study about how uh, clinician experience as far as their joy in practice was affected from the coaching or the class.
Would you have regarded, just thinking of a classic sort of DMAIC, framework for measurement, often we think of, well, what's the measures that are going to tell us if we succeeded? Did you have any countermeasures that you were concerned about, or, adverse ways that you thought of that this might affect clinicians or patients? Or did it seem like mostly it would be positive or not?
We did not have any countermeasures because again, we kind of tried to approach this more from a research lens and a quality improvement lens, and just to see if there was any differences, any change in patient experience scores. Because I think one of the interests that leadership had going into this study, and one of the reasons they were interested in it is because they often had clinicians that maybe struggled with their patient experience scores, but they didn't really have anything to say like, hey, you should do this or that because it's going to help. And so I think there really was a key interest from the group and from the study is to whether these measures really do make a difference or not. Are they effective at all?
Mhm. So from a
We often
logistical, oh, go ahead.
Oh, I was just going to share real quick, because it made me think of is we often hear from our clinician colleagues, and many often perceive uh, patient experience as whether the patient likes me or not, right? That it's the
Mhm.
popularity contest. And the effort in this was really to try to show how these interventions, which again, as Chad had shared before, if Chad offered someone coaching and they said, well, show me the data, he didn't have it. And so that again, that was that other component, was to say, okay, if we're encouraging staff to consider the communication class or consider a coaching class, can we put understanding many in healthcare love data, love numbers, could we add that behind? Not only again, us understanding, and as you started at the outset of how important communication is, not only within healthcare, within medicine, but our day-to-day lives, we were trying to add some of the metrics behind it to show people some data that it could help improve their patient experience scores.
And so outcomes.
We looked at, again, our patient experience surveys. And for those of you that are not familiar with them, in our organization, we have actually 10 questions that clinicians are evaluated on. And those questions range everywhere from, you know, the clinician had concerns, expressed concerns for my questions and gave me adequate explanations to the likelihood that you would recommend the clinician. And as you know, Dr. Morgenthaler, likelihood to recommend is in our organization the most important question, because it conveys that the patient has trust in the clinician, and also within our organization as well. So we looked at our patient experience scores of all 10 questions, especially the likelihood to recommend. And what we found was the composite scores. When we looked at the composite scores, all 10 questions, the clinicians that were in the coaching group did have overall higher composite scores than the coaching or the no intervention group. So that was positive. The class and the coaching groups actually improved in 9 of the 10 questions, but there was really no statistical significance when compared to the no intervention group.
And part of that challenge again goes back to our smaller sample size in this study. I mean, we had hoped for a total recruitment of at least 30 clinicians, and did not have that part. But again, I think it still speaks to, from what we could gather from our pilot group, enough of positive and improvements and opportunities to then expand this on a larger scale within our primary care departments and divisions, so that there's a larger group in the future.
So let's talk about that. So you learned some things from this original pilot. What's the current state of the project? Are there other things that you're doing or expanding on based on this initial work?
The current state of the project is we have completed the study. We're in the process of disseminating our work. We actually presented our work at a national conference earlier this year. We actually just met as a team yesterday to work on revisions for a journal for this our manuscript. So we're hoping to get our study through publication here in the next few months. And then we're looking forward to disseminating this back to leadership as well, to show, what the outcomes of the communication and coaching interventions were for the primary care clinicians that participated in our study, and to begin to think about how we can move this research into implementation within primary care moving forward.
So Jen, what do you think the impact will be if this is moved forward and it's, I guess you'd say it's offered or maybe even strongly recommended for each provider that they undertake coaching? What do you think the impact will be on patients and on staff in your practice?
Well, I think always whenever we work to improve something, the winners at the end of that in healthcare are always our patients. And so I hope that as we make coaching and or communication classes more available and more encouraged throughout our organization, and I hope that clinicians become more engaged with that. Our hope is that, of course, our clinicians have continued improvement in their patient experience, but that our patients have better outcomes as a result of that. They're more engaged in their care. They're more connected to their clinician. And so that's always a hope. As an educator, I hope also that we understand how powerful and how important it is to teach the next group of healthcare clinicians coming up through our medical academic center, the importance of communicating with patients, and how important learning communication skills are to having good patient outcomes. I think that we've always thought of maybe, I think the term soft skills are maybe not as important as, how much we know as clinicians, or how much we can, how good we are at evaluating and treating our patients. But I think having good communication skills is really important to having good patient outcomes.
Dr. Allen, what would you say to an organization that's listening to your story and the work you've been doing, and maybe we want to start on something like this, or we want to learn more about starting work in this area? What kinds of recommendations might you offer?
This is really important. There's a few aspects that I think are essential and important. First is to make sure you have colleagues with some expertise in communication and or coaching, particularly if you're going to be teaching a communication class or have someone with coaching. You want someone to have a very specific training in that area, not someone who just says, "Oh, I'm really good at patient experience," or I'm good at this," because it does take a skill set, and it's important for your first explorations at this or opportunities to be positive for the clinicians and staff involved. So again, finding an expert in that area would be important. And also the other part is to not feel like it needs to be an implementation right away, right? Within your organization or within your area, it doesn't need to be, okay, well, now we're going to mandate everybody to coaching or everybody to communication class, and we're starting this. It's like most things we tell people, tell others, right? Start small, right? Don't try to tell yourself you're going to have this for everybody, because if you can again create these small areas or hotspots within your organization or within different areas, and I would encourage people, if they have disciplinary areas or multi-specialty areas, is to even find small pockets within a dermatology area or rheumatology, and then also in primary care. We often, and this is why we were very focused on within primary care to make sure it was across our 3 departments that are within primary care. So family medicine, internal medicine, and pediatrics. Because even within there, sometimes if something is done within one, the assumption is, oh, well, that can just be done within family medicine, but that's not the same in internal medicine or the same in pediatrics. So again, trying to create some overlap and or have these small places where you start, because then you're able to come back again as a larger group, or if you're looking to put this throughout the organization, and now you have the buy-in because you have these small areas where you were able to also work through challenges and figure out your pain points, but also have your successes that can come back to the group.
Well, wow. Well, I just want to thank both of you, Dr. Allen and Jen, for sharing your experience and insights and the story of what you did with us today. Look forward to seeing your manuscript in publication, and if we have an opportunity to get a link to that, we'll be happy to put that along with this podcast so that people can find it more easily. This work really reminds us that every patient encounter is an opportunity to build trust and understanding and connection, and for personal satisfaction in the work that we do. So thank you both so much. Is there anything you'd like to add as we close?
I just like to say I appreciate the opportunity for Jen and I to be able to be here and to share this work, because you said, and again, we are hoping for the publication and would love to attach that, because getting to share this work with others and hopefully help support other areas, other clinicians. And as Jen said, again, the people we want winning at the end of this are our patients, the people that we care for.
Wow, thanks so much. Well, one theme that stood out to me from today's conversation is that communication is not just a personal attribute that we all just kind of are born with communication, or maybe we are, but it doesn't mean that it can't be improved. And I think that's the issue, is that it's a skill that can be strengthened through intentional practice, feedback, and support. Your randomized trial in primary care reminds us that improving that patient-clinician communication is not only about patient experience scores, it's also about clinician well-being, as Jen shared with us, and it's about the organizational choices that we make to try to allow our people to do their best work. So here's my challenge to our listeners for this week. Choose one conversation that you have, maybe with a patient, could be any conversation. Before, during, or after that encounter, practice one intentional skill. Listen a little longer, explain a little more clearly, ask for feedback from someone who might have overheard the conversation to learn how that conversation landed. And maybe, as Dr. Summer Allen said, just start small. Little tests of improvement on your own may be one way to start. So thank you all for joining us for this episode of Key into Quality. We hope today's conversation has provided some practical insights into how coaching, reflection, continuous learning can strengthen communication and improve the patient experience. Mayo Clinic's Key into Quality aims to highlight first steps in addressing important quality challenges in your organization. Our goal is to improve quality for patients and the patients we all serve. Share what you heard today by pointing your colleagues to our podcast. It would be helpful if you'd leave a review or follow us so you don't miss future episodes. And until next time, continue to pursue opportunities to learn, strengthen human connections in healthcare, and advance quality one conversation at a time. Until next time, goodbye.